Welcome to the CMDA monthly meeting.
Why are we having this?
Is this a comment? Oh, we got a lot of people with comments. Feel free to jump in, of course, but on the screen you'll see the agenda for today. And we're so happy to have you here at our monthly meeting. And we have several exciting announcements to make. I'm going to go ahead and start. I'm Sing Pallet. I'm the president of CMDA. I'm going to stop sharing this agenda in order to show you a different page, which is this one. This is our first announcement of today. Early in March, many of us went to the AMDA PALTC23 Conference. It was a really fun conference with all the state chapters getting together for CME and CMDA reception and all sorts of exciting things that actually Dr. Runkel is going to highlight. But I wanted to start off by congratulating Dr. Vikas Reddy, who was awarded the AMDA Clinician of the Year award. And you can see he had a picture. He went up and got his plaque, and there was a nice write-up online. So congratulations to Dr. Reddy. And I think you're online today. Are you still on?
Yeah, I'm still here. No, thank you so much.
Yeah, congratulations on your award.
Yeah, I'll just say I work with him and he deserves it.
No, I appreciate it, Dr. Gong. I can't do any of that without you guys. So it's definitely an award for everybody, and glad I could represent Colorado.
Yes, we're very proud that Colorado got mentioned. So thank you so much. I'm going to go ahead and pull up our next presentation. Dr. Katherine Runkel. So this year, as part of the AMDA PALTC conference, the conference always has a futures program for people who are starting off in careers in geriatrics to introduce those people to post-acute and long-term care. And this year, CMDA was proud to provide scholarship and sponsorship money. And one of the people who received that money was Dr. Runkel. She's a fellow at the University of Colorado. And she was kind enough to put together a presentation to let us know what this experience was like for her. Oops, I'm looking at the slides, but I don't think I'm sharing them.
Not yet.
Do that. There we go. Okay, you take it away.
Perfect. Well, thank you guys so much again for sponsoring my trip to Tampa. It was a great time, and hopefully I'll be able to explain that with this short talk. But yeah, we ended up having 86 futures this year, which was their largest class ever. And they were so excited to have us, and you could feel it in the room for the whole conference. Everyone was so excited to meet us. We had like a tag that said we were futures, and ended up having a lot of conversations just because of the futures program, which is such a unique aspect of this conference that I had the opportunity to be a part of. So thank you guys so much. So this year, the conference, of course, as many of you know, because you were there, was from March 9th to the 12th. And Futures specifically is the first day of the conference, and it's an all-day event. And we got to learn more about how to be a provider in that setting. If you could advance one slide.
Yes.
So some of the things that we focused on during the conference that was specific to us as futures for that first day was we did leadership skills, and an excellent talk from Dr. Suzanne Gillespie, our immediate past president of AMDA, and she was so inspiring and sort of helped us look into our own values and how we translate that to our leadership and our jobs and careers, and help prevent burnout and burnout in our coworkers. So that was a really inspirational talk, and opened up sort of the futures day. We also moved into the role of the interdisciplinary team, and we got to hear from Dr. Amita Patel, pharmacist Jennifer Porowski, and then nurse practitioner Barbara Resnick, all big names in the AMDA community. And they were able to listen to really complex cases and discuss sort of how they would respond to it, and interesting alternative ideas that were sort of beyond maybe what we've learned in fellowship, or creative ideas. Part of that talk also included a small breakout session with current practitioners in the long-term care setting. And so we got to break out with other futures, sort of collaborate and talk and discuss and how we would handle complex situations, and then ask, of course, the expert that we were paired with. So that was a really great way to meet some people in the field and also each other. We also got to hear from Dr. Saltzman about risk management and the challenges in long-term care and how to handle risk, but also balancing patient preferences and family goals with that in mind. We did another complex clinical case presentation from fellows and how fellows had responded to those complex cases. And sort of that was more of a learning from each other, which was great. And then they have this other great program that's called a Futures Friend. And so it's a voluntary program that they pair other current futures with past futures and mentors. So I got to meet with Dr. Kerr, who's a hospice and long-term care medical director in Indiana, and she was a futures participant back in 2015. So she is kind of an automatic contact for me as a mentor. And we talked about careers and how to optimize your contracts in long-term care and what to look out for in the future. So I expect that to be a longitudinal relationship, and really grateful that Futures connected me with her to start off with. And then if you could move forward one slide. So that was all day, one day. And then of course we had the rest of the conference to go to as well, which was fabulous. The ones that I want to highlight, the year in review was a lecture on current data and 12 articles that the panel sort of selects from, in articles that they think are really practice changing or interesting that we should all keep up on. And the three that I thought were the most interesting to me were these three. So there's one on the impact of upgraded lighting on falls in care home residents. So this was a trial where they actually adapted their lighting system to fluctuate throughout the day. And so they would have high intensity blue light during the day and then lower intensity lighting at nighttime. And they actually found that this reduced falls. Wasn't a pharmacologic or staff driven intervention that did actually have a reduction. Unfortunately, it was pretty expensive in the trial to make this adjustment because it was an automatic system with these fancy lights, but an interesting alternative to all the other things we try to do to prevent falls. And then there was another trial on sunlight exposure in older adults in nursing homes. And basically this trial did show that 5 days a week for 4 weeks, 20 minutes at a time, they did see an increase in vitamin D despite some of the physiologic differences in older adults. They can still increase their vitamin D with sun exposure. They did have a couple other articles that argued, does vitamin D actually matter as much in older adults as we think it does? And we had a really rousing discussion about how much we should be replacing vitamin D during the comment section. And then the last one that I thought was really interesting was pressure injury prevention in nursing homes and how often we really do need to be repositioning patients. And essentially they showed non-inferiority in like Q3 or even Q4 hour turns. So maybe that burdensome staff Q2 hour turn issue could maybe be relaxed a little bit based on that trial. I also went to a skin care talk, which was fabulous. The takeaway basically was try not to use steri strips because they cause more harm than good. I went to the welcome symposium regarding they're trying to develop this web-based learning module system and how to expand this to residents and fellows. So that was really exciting to hear about. A great lecture on health policy and what AMDA is doing to advocate for our older adults in nursing homes. And that was really inspirational. And then the last really exciting talk that I went to was this non-pharmaceutical approach to managing behaviors in memory care, which was an excellent talk with multiple providers and how they manage complex cases. I think is an ongoing challenge for everyone in the long-term care world. So that was a full house. That room was completely packed. Everyone was really excited to hear that talk. So overall, it was really educational and a fabulous experience. And then if you could just go to the last slide. So the pictures on the left are of Tampa. This is like right on the Riverwalk. I got to explore. The lights actually look like that in the lower left. They have this beautiful river walk that I got to walk around at night, listen to some live music, and it was just a really beautiful and sunny, warm place compared to Denver today. And then that's me in the upper right at front of one of the posters. The lower right is a picture at the Futures dinner that they hosted the night before the whole conference started, which is an awesome way for us to all meet each other in a more casual setting. And then the center picture is just a primer for the next meeting is in San Antonio, and it's actually going to be from Saturday to Tuesday next year rather than the typical Thursday through Sunday. So anyway, I just wanted to say thank you guys so much for supporting my trip. It was a great learning experience, and I felt so included in the community as a Futures participant. So thank you guys so much again.
Thank you. What a fabulous recap. Anyone have questions for Kate? Well, we're so glad that you got to go to this conference and very proud that you also got to help represent Colorado there. If anyone has questions for Kate, just let her know. We'll go on to our next speaker. Oh, go ahead. Thank you.
Oh, I'll just put my email in the chat if anybody has follow-up questions.
And thanks for announcing next year's conference too. I'm glad that you did that. Our next speaker is Dr. Leslie Eber, and she's going to give us a preview of our own conference here in Colorado, which is taking place on Friday, April 28th.
Hi, thank you for having me. I'm so excited to see everybody today, even though it's really snowy out. I hope you're all staying warm. So I wanted to talk about our annual CMDA conference, which is this month. It's hard to believe, but it is. And there are just 11 days more before early bird is gone, and it will cost you more to come to our annual conference. So we wanted to take this opportunity to talk to you about why you should come. So this year's conference is really educational and innovative. We're going to talk about fall prevention, congestive heart failure, Parkinson's disease, polypharmacy, trauma-informed care, and deprescribing. So it's the full Monty. But it's also the only day, one day a year, that we all come together as a community. We get to see each other, we get to recharge, we get to reconnect with one another. And we're going to talk about some self-care, how to make sure that all the people that we're working with and our colleagues are well taken care of, and what can we do to support them. And so I encourage you to sign up and come. You can go to cmda.us. And I think that Dr. Pallett may show our agenda.
I'll do that right now.
Oh,
I just put the link for registration in the chat box also.
Oh, thank you. And so, and this is also the time when we not only join together, but we learn from one another and we reconnect. And we also support CMDA for the whole year. And so we have vendors that are gracious enough to support our community and embrace all members of our community. So we have directors of nursing and administrators and PAs and nurse practitioners and doctors. And so it is a full breadth of interdisciplinary learning. And I'm happy to answer any questions, but I encourage you, it's on April 28th. It's for the whole day. And it is a very reasonable and inexpensive way to get a lot of education and connection. If you're a CMDA member, it's $90 and you get breakfast and you get lunch and it's really good food and you get cookies. So right there, it's a great way to spend a Friday and update yourself. Does anybody have any questions? Okay, I look forward to seeing lots of you there on Friday, April 28th, and I'll see you there for breakfast.
Perfect.
Thanks.
I plan to be there too. Can't wait. Well, let's head on into our updates. We'll start with Jenny Albertson with CHCA. Hi, Jenny.
Hello, hello. I am presenting to you from our assisted living conference today. So pardon the hotelish appearance. We are happily hosted Dr. Reddy earlier to talk about antipsychotic use in assisted living settings, which has been an increasing focus. So I would like to share some slides with you all. And as always, I will provide these to Dr. Pallett afterwards so that you all can benefit from the links and whatnot, should there be anything of interest to you specifically.
Appreciate that.
Yeah, you bet. Okay, so here goes. Slideshow, there we go. Okay. All right, first off, in case you are not on the down low with CMS's memos that they like to release on a regular basis, first off, these are the interim pieces of guidance that they distribute to our entire profession and to the state survey teams to update their guidance as to what is to be enforced, how is it to be enforced, and so forth. This particular one was released March 30th. And it's entitled Enhanced Enforcement for Infection Control Deficiencies. However, I do want to highlight that this is somewhat of a relaxation of the deficiency citation patterns that they have followed since the beginning of COVID. So a bit of good news from CMS today. First thing is that CMPs will no longer, these are civil money penalties where you get a fine assessed for your infection prevention deficiencies. They'll no longer apply for all F880 infection control citations. What does this mean? Major money will no longer be flowing out the doors of our nursing homes for these citations. And we all know they gave them out like candy during COVID. Nearly every facility had one. Additionally, if you are cited with a CMP at 10,500 approximately, you automatically lose your ability to train nursing assistants within your doors. And this hit almost every one of our members at some point over the course of the pandemic. We are seeing people restoring now their abilities to train CNAs toward licensure, NAs toward licensure as CNAs, but this is a huge improvement. So what they did is they changed the enforcement pattern so that you have to actually be cited both for two infection control deficiencies, F880 and F887, which is immunizations, in order to get to a higher level of deficiency, unless they find something egregious that they would put under the actual harm category of G. They still reserve the right to do that, but the automatic citations for, oh, I saw someone hand wash for too short of a time, those kinds of things will not automatically result in a loss of CNA program and an assessment of a penalty. So it has to be at a level 2 or higher. Let me give you the grid. Here's the deficiency citations guidelines. This is a lot simpler to look at than that narrative previously. They will encourage directed plans of correction for facilities that have non-compliance with both F880 and 887. So you're stinking at infection prevention and control, and you're also not immunizing people according to the requirements. That's when they want to direct you. But what they want is for you to work with Telligent to do so. And we all know that Telligent is our partner, right? They are not part of the regulatory arm, and they provide us with a great deal of resources and education. So this is a massive improvement. If there is a citation at an actual harm level, G, H, or I, or if you raise all the way to an immediate jeopardy level, they reserve the right to increase those penalties. And they actually have shortened the compliance date. So they're going to start denying payment for any new admissions under Medicare within 15 days if somebody reaches an actual harm tag for infection prevention. So that is an increase in severity. But honestly, the way they've been enforcing has been so broad-based. This is a pretty significant improvement. And Telligent has been directed to provide attention to facilities that are having difficulty with infection control ongoing. If they have a history of challenges in this area, they will be giving a call. Interesting data coming out from ACA, our national partner, of course, on NHSN reporting. I thought you all might be interested in this. You automatically see deficiencies cited for reporting glitches in NHSN. And when I say glitches, I mean in facility processes, not on the computerized side of NHSN reporting. Many communities struggle with gaps in their handoffs on NHSN reporting on the weekly basis for vaccine reporting and infection rates and so forth. So we're still seeing those citations. About half of the ACA member facilities had several weeks of citations ongoing. So they're either not realizing that they are having the error or the right person who can fix the problem is not getting that attention, or they are having systems that are so broken that it takes them a while to recover and fix them. That deficiency can result in fines, so it's worth people paying attention to it. And we also have ACA resources for how to easily report and so forth, and I can be a resource in that as well. If you want to look at your particular communities, the Q-Core database, this gives you some screenshots on how to drill down. It's pretty straightforward and intuitive once you get in there. This makes it look a little complicated. You can run all kinds of reports on Q-Core about deficiency trends, the history of deficiencies in facilities that you're either competing with or that you happen to be with. At any rate, there are a lot of resources on this database, and it's provided by CMS directly from those that cite, right? So it should be accurate and up to date, and it is kind of our Bible as far as understanding trends. You can find out whether your buildings are getting NHSN deficiencies by looking here. Quick note on flu vaccination. A lot of communities have been very confused about how to report and when to report. So I have posted this on my blog. This is just a quick reference for you. EM resource is twice monthly data entry. It covers our state reporting for flu vaccination data. The final cutoff is May 15th for the national requirement and for our statutory reporting requirement. And the NHSN report that they will do on May 15th will cover and meet the requirement for Colorado's reporting system as well. And if you are not seeing a good uptake on flu vaccines in your communities, they are at risk of deficiency citation. The statute reads, the 11.2.3 above here, facilities and agencies shall ensure that 90% of employees and direct contractors have received the influenza vaccine during a given influenza season. They have to hit that 90% by the time they report on the May 15th date. Otherwise, they automatically are cited with a deficiency at a state level. This has been of interest to a lot of providers, and I wanted to just update you on the progress here. CMS is conducting their schizophrenia audits. They are looking at MDS coding for schizophrenia, particularly for buildings that have QMs that are high in the antipsychotic area, but they're triaging based on however they scrub. They're kind of keeping that close to the vest. If selected, nursing homes do have a choice. They can undergo the full audit, or they can forego it by admitting fault. It's kind of like a plea deal in court. They could admit fault in inaccurate coding, and then they can do their plan of correction as a result. If a facility passes the audit, their 5-star ratings will not be impacted, but if they fail or forego it, their 5-star rating is impacted. We all know that that stinks. So here is a potential impact of failing an audit on an overall rating over the first 6 months. If they're already a 1-star, they're not going to see that dropped. If they have 2 stars, you can see the impact there. This is what we're projecting out of those that have been selected so far. And if you need to understand your 5-star rating for your community better, I thought this was a nice tool to provide to you all. If you're a member with CHCA or your community is, you can access this long-term care trend tracker data. It scrubs all kinds of indicators for you, and I can help access those reports and get them to you if you need. And the top line report gives a great summation, and you can pull projections on where your 5-star rating will be going based on the current coding that is seen in their system. And then last but not least, I realize I've spoken too long already. Upcoming events and education. Today is the AL conference. Our next in-person event will be Spring Conference in Beaver Creek, May 24th to 25th. Please join us. It's one of the only times I can afford to actually stay in Beaver Creek because they give us a nice room rate. I will be hosting an Essentials of Nursing Home Administration virtual 3-day seminar for those of you who have new administrators who need to be marinated appropriately. And then we're doing the same at the same time for assisted living administrator 40-hour training for the 11th through 13th and 18th to 19th. And a lot of our NHAs, nursing home administrators, are starting to get additional licensure in assisted living in order to operate better in a community that has a continuum of care. So we should see a lot of people increasing their proficiencies there. So thank you so much.
Well, thank you, Jenny. I wasn't even paying attention to the time. Those are all very timely and relevant announcements. And thanks for offering to share the slides. Does anyone have an immediate question for Jenny?
I will put the link to the QSO memo in the chat.
Thank you.
Could I clarify what conference that is in Beaver Creek?
That is the Colorado Healthcare Association Spring Conference. It will be for both skilled nursing and assisted living providers.
Great, thank you.
Thank you. Our next update is coming from the CDPHE. Chad Fear is here with the Nursing Facilities Division. Thanks, Chad, for being here.
You betcha. Hey, I can help with time and just say ditto to what Jenny said.
I agree. A lot of great stuff.
Jenny, that was a lot of great information. And some of what I'll talk about is just, maybe underlining some of those areas that you had mentioned. But to give you first kind of an update with what's going on in our office, I want to let you know that we have continued to make progress in completing the backlog recertification surveys that was caused a result of the COVID-19 pandemic work stoppage a few years back. As part of our performance measure, we need to reduce our backlog by 50% by September 30th. And in order to accomplish that, we're working on our own bandwidth, which not only includes hiring new staff, but getting those staff trained to the point where they contribute independently on surveys. And, despite having had some resignations, we've been able to reduce positions openings on our team by more than half. And additionally, we would like to send out another request for proposal for additional assistance from a contract survey agency. And kind of what that has created is, you may notice some of your facilities that are a part of a larger corporations, we may be visiting a facility for a second time before we've been able to get back to some of the longer standing, more overdue facilities. And that has to do with our approach to keep facilities from entering the backlog so that we can actually make progress on this. So we're getting there and we have a plan to do that. So I can see us being successful in getting out to all of the facilities, hopefully within a reasonable period of time. I like to bring an update to this meeting often with some of the IJ citations that we've seen, the immediate jeopardy situations. And this goes back to the beginning of the federal fiscal year, so back October 1st. We have had a few immediate jeopardy situations in the last few months, but we continue and have seen IJ citations, facility acquired, avoidable multiple stage 3 or stage 4 pressure wounds, major medication errors, smoking hazards, elopement, hot water temperatures, withholding CPR when there was an advance directive to resuscitate, infection control issues. And Jenny had mentioned previously that that is an area that we actually are able to we have found immediate jeopardy situations related to infection control. A specific case was around sharing glucometers, and recently I believe CMS had called an IJ on one of their visits for neglect. Did want to emphasize that some of the recent areas of focus, and so these are some of the things that we're seeing come up, and in conversations with our regional office and CMS, these are some of the areas, they're all important, but these are some of the areas that tend to float to the top in terms of attention. As always, abuse and neglect, inappropriate or unsafe discharges. Jenny mentioned the audits that CMS is conducting around the unnecessary psychotropic medication use and how that might affect the 5-star rating. The process of quality assurance and performance improvement is something that is being looked at, I think, with I shouldn't say greater scrutiny, but there's more attention placed to that process, in that that's really fundamental to self-identifying areas where change can be made, improvements can be made, and that those changes are sustained in improving the care for residents. Behavior health, Jenny mentioned earlier, immunizations, infection control and the infection preventionist. Language and communication is an area that is receiving some focus. Staffing, and also ongoing patterns of non-compliance. And we're working through right now some new language and rules There's been a rewrite, some revision to the State Operations Manual, Chapter 5 around complaints and facility reported incidents. We're triaging between 200 and 250 facility reported incidents a month right now, and approximately 4% of those have led to on-site complaint investigation visits. We are getting additional clarification to the State Operations Manual Appendix PP related to abuse and neglect and the psychosocial outcome severity guide. And hopefully we will have an upcoming collaboration with CHCA and the rest of the community in having discussions around that. We've also been looking at rules, state rules around dementia care, visitation, and infectious disease mitigation plans. And probably more to come on that as we I guess have some of those details fleshed out. That's what I have for you today. And that was kind of a long ditto, but ditto.
Wonderful. Thank you. We always appreciate your updates and what you're seeing out there. Are there questions from the audience? Thank you so much. I'm glad that you're in conversation with CHCA about that. That was about the this antipsychotics, right?
Abuse.
Abuse. Thank you.
Prevention, I should say.
Yes,
Abuse prevention.
I should hope so. Well, thank you so much for all of your updates. We appreciate all of you taking some time out of your day to join our meeting and update our listeners. So now we will turn to our panel discussion. We have several people from CMDA plus a special guest to talk about strategies for implementing antimicrobial stewardship. I'm going to go ahead and let Dr. Chris Horton introduce the panelists and take the topic away.
Hi, welcome everyone. Thanks for joining us at CMDA. I would like to do one last plug again for our annual conference. We are going to have a panel, a fall panel, so I think that'll be great. And this is for you guys. So if you have topics in the future, please reach out to Sing and let us know what you'd like to hear about. I don't know, it seems like this is the first time we've done a panel via Zoom for CMDA. So let's see how this goes. But we have an excellent panel. It's actually my honor to be the moderator. And we have Travis Neill, a physician assistant. We have Josie Bacon, registered nurse. And we have Dr. Rebecca Jackson on the panel. This could be a really large topic. And so what we've decided to do today, and again, if you have questions, please submit them in the chat and we'll get to them at the end. And if you have future topic suggestions, let us know. But what we decided to do today was look at what's an effective strategy and framework for implementing an effective antibiotic stewardship program. So I was actually going to start with Josie because she's been so greatly nominated. And Josie, you're the infection preventionist for Inglewood Post-Acute. So you pretty much collect and report data on infections at the end of the month in QA, correct? Is that all you do? Have some feedback.
Sorry about that. Hopefully Josie heard you.
Yeah. Till we get Josie on, let's ask Dr. Jackson what you view your role as in infection prevention.
Try to tell you about my experience. So I work for a small system up here in northern Colorado. We have 5 nursing homes. And when I started at my first nursing home for Columbine, there was 50 attendings to 90 residents. And so the variety of prescribing habits that we saw was pretty broad. And then as the group has grown, I've been there now for 9 years. And it's been a while, but I think at least in 2014, we developed an antibiotic stewardship committee with our pharmacist that works here, our nursing leadership, who kind of helps with the oversight at the facilities. And we slowly started developing a process where we actually came up with a prescribing form, because so many things are still on paper at a nursing home. We have a small group of nurse practitioners and now doctors that are in the facilities. So we wanted to make it as easy as possible. I think that's the key, at least in my experience, was making sure that it's accessible and that it works into people's workflow, because it has to be simple and it has to be easy for them to utilize it. And so we actually created a form, and I'm not sure how best to share that with the group, but I can send it out later too, or if somebody has an example of it, they can share their screen.
Yeah, I think I forgot to mention that when I start. We are going to distribute a bunch of different documents for people to use or to consider using. And I appreciate that, Dr. Jackson. We didn't want to get stuck in like, you have to use this method or that method, but I think that you bring up some really good points. And I think one of the points is it's really important to have provider meetings and get everyone on the same board and discuss whatever your policy is. And the second thing that you brought up is to really have some programs like this, some specifics that the providers can agree with, as well as nursing and something to move forward with. So I think you've hit on a couple of key points, and I appreciate that. So for those of you that are looking at your infection prevention program, please make sure that that education and provider meetings is an important part of it, and then have some tools to use. And I think Josie is back online with us.
Yes, I am.
Great, great, great. So you're an infection preventionist. So your job at the end of each month is to report the number of infections at QA, correct? Is that all you do?
No, I mean, that is part of what I do, but I look at everything as a whole. Like it starts with the education, but I speak with providers one-on-one. We like to do provider meetings as well, with you included, so that you also know what's going on in the facility as well, and come up with best practice strategies to facilitate that education, not just for the residents, but the families as well. And then that education also starts from the nursing staff on the floor as well. And that way we can be like one cohesive unit, and with the antibiotics to keep them, to make sure that they're effective or not.
Yeah, that's great. And no, I was joking with Josie. I actually recruited her because I think she's an excellent infection preventionist. And one of the things that I appreciate is that this is a team sport and this is a team approach. And I appreciate that it's not just the medical director implementing or saying that these are the policies we're going to follow. It's actually having people in the field and having people in nursing be involved, and having your infection preventionist should be comfortable addressing anything with the providers, and including, why are you ordering that antibiotic, or how long, why are you ordering it for so long? One of the things that came up in our discussion, Josie, is you had a unique, one of the things I think we can all agree that people struggle with antibiotic stewardship is what happens on call, after hours, on the weekends. And I wanted you to touch on your process a little bit to give people an idea of what you can do on call to help educate your nurses.
So I do the education. However, I have what I call a nurse's go book. And if they question whether or not antibiotics or labs need to be run, it's just a quick yes or no. Do they have do they meet these criteria? We have their McGear's criteria, they're listed. If they do meet it, then yes, you follow this little pathway. It's really just a generic pathways thing, but it is something that they can do, and they feel a little bit more empowered when they're speaking to an on-call, because 9 times out of 10, the on-call doesn't know this patient. So it just empowers the nurses to say, this is what's going on. However, we're going to continue watching, or this is what's going on. We probably need to do a chest x-ray, stat lab, something along those lines. And it helps them not only be empowered, the floor staff, to be a little bit more bold in what they're working with, but it also helps paint the picture for the on-call provider late at night as well. And then it goes back to that whole cohesiveness of, it instills a little bit more trust in the facility and the nursing staff as well.
Great. Great. That sounds excellent. I think that sounds like a really good program. It's working for you. And Travis, as a provider, what are some things that you can do, and help the facility with infection prevention and appropriate use of antibiotics?
Sure. So I actually had an interesting experience over the past, say, year or so, where I was doing a lot of reviews, and then I stopped doing reviews because COVID kind of took over, and then started back doing reviews again. And it was really interesting being a provider and, being on that side of the decision-making process, and then flipping back to doing reviews of other people's prescribing habits. And, I think it's really easy, or maybe I should just sympathize with providers for, the pressure that we feel a lot of times to, start an antibiotic, even if it's just in case, that we might plan to stop later, any number of scenarios. And after I went back and started doing the reviews, it's kind of the metaphor is, everyone should be a waiter once, so then you really appreciate your waiter, and tip appropriately. And you just have a whole nother appreciation when you take a step back and look at the data and understand why we're doing this. So, I think one thing that resonates is the direct communication with providers. So infection preventionists in particular, feeling comfortable to reach out and talk to providers. And so, I would just put a plug for encouraging more of that. We do typically see, about the sort of 80-20 rule where, 80% of the antibiotics are typically prescribed by about 20% of the providers. And so, you can target a lot of that education to those specific providers. But in doing reviews a lot, I will say that the more direct communication we can have with providers, the better. And, certainly if anyone, Josie or anybody, have suggestions for how to do that, I agree, having an infection preventionist that is willing to challenge prescribing habits, and maybe a culture that's supported by a medical director around those challenges, so that it doesn't become defensive and confrontational. And because education, in my experience, isn't enough. You have to get to the providers that tend to go outside the protocols and the criteria more often than not. So I think as a provider, just sort of emphasizing that communication, and certainly having people share strategies that they think are effective in terms of reaching those providers and changing their habits.
I think that's great. I think that's well put, Travis. And I think I do look at it as my job as medical director to support the infection preventionist. So I hope that you feel supported, Josie. And I think that that is one of the key jobs of a medical director, is when the staff comes to you and says, hey, this provider is not following the appropriate criteria, they're not following what we established in the provider meeting, I need you to step in. And so that's absolutely 100% a job of an effective medical director, to be able to feel comfortable to step in and have those difficult discussions. Dr. Jackson, would you be able to talk to us about the Loeb versus McGeer criteria and when we should use? And again, we're going to distribute this information at the end of the meeting, and Singh will email a lot of documents, so you can pick and choose what works.
Yeah, we ended up, I believe ours has the Loeb on it just because it matched what the facilities were already doing. So we kind of chose something that was congruent with what the nursing staff was doing in our facilities. So, I mean, I would love to hear why somebody else, might have chose to go with McGregor versus the Loeb, because we kind of did it because it was already established within the facilities that we were serving. So that's how we ended up kind of going that direction, to make sure that we were congruent with what the nursing staff was aware of. So, and
as I understand it, the Loeb is a little more proactive. Should we order this antibiotic? Should we start it or not? And McGeer's is looking in retrospective. We've ordered all these antibiotics, and which ones maybe we could have avoided.
Yep.
Josie, what So, the states the surveys are looking at antibiotic infection, stewardship, infection control. What are some things that you do, or you feel like you do, that you could demonstrate to the surveyors and to the state that you are actively involved and take an active role in antibiotic stewardship?
It's the tracking and the trending is the biggest thing. Obviously, everybody knows like we do like an infection control map every month. And so kind of watching that. What I also do is I pull orders every day, new orders. I look for new antibiotics. I look for new changing conditions. I review the labs myself. I know this isn't standard for every DON or infection preventionist, but it is one of the things that I do. It is what I have found to be key, because then we're looking at the labs, like we're looking and we can talk to the providers one-on-one, so that we as nursing are also, just we have this person at the front of our mind if the labs are good or bad. And that's the biggest thing. And that's what I explained to a surveyor about my infection control process. And if I start to see a trend, what am I doing? What is going on? And what education do I then need to provide to my floor staff and to my housekeepers and to my cook staff? Like, what are we doing? And how is this being handled effectively?
Great. Another thing that I see you do that I think is really good is during the QA process, you actually report on what interventions you made. And so maybe you stopped an antibiotic, maybe you shortened it from the hospital. And so I think that's an important step. The QAPI documents are protected, but I think it's showing that you have an active role.
Yes. And then that part also goes with the education up front with the families and the resident as well before doing that, because a lot of them think that the antibiotics are a be all end all, like this is what's going to cure me. And it's starting that education with them as well, saying, hey, this is why we want to stop this, or hey, this is why this is not appropriate at this point in time. And then to have like the provider groups in there go ahead and back up what we're saying in agreement, then, it puts them at ease, knowing that we're not just throwing extra medications on them and that we're doing this for a reason in the long run.
So I'll throw this question out to the whole panel. Who's responsible for following up on labs?
I believe it's both the facility and the providers.
We have everybody responsible. We have a double check process where the nursing is like receiving those labs, but then making sure we have insurance that they are following up with the providers on that too.
I agree. Again, it's a team sport. So a provider orders the lab, you ordered the lab, you should take an active role in following up on that lab. So but I do think it's important as part of your infection prevention strategy implementation is to have a specific procedure for addressing labs. So whatever that is, everybody has a different, you can use point-click care or not. I think you need to be able to demonstrate to the state, this is how we follow up on labs. I have seen tags issued where an antibiotic was started, there was a UTI, there was no follow-up, or an antibiotic was started, it was the incorrect antibiotic for a UTI, and the state did issue a tag for that. So I think it's important to have some process, very specific process in place for following up labs and addressing those. What other question? Josie, is there anything else that, have you seen other tags issued in the past for antibiotic stewardship?
Chris, I'll throw one out there.
Please.
I would bet that at least half, if not more, of our inappropriate antibiotics come from patients that are coming back from the ER, the hospital, the urologist, and we look at them and we know they're inappropriate, but nobody wants to touch it.
Yeah, I think that's, again, an important part for the medical director. And I think, Josie, you've reached out to your medical director before asking them to stop or give support for discontinuing an antibiotic from the hospital.
Yes, I have. And as you know, I have pulled you in on these complex ones, especially when they're being directed by ID or coming from the ER and they're saying, this is what they have. But it's something that the patient has already had, or has actually just been treated for. And I know the provider then gets a little nervous about pulling them. And so I know I have pulled you in to say, hey, this is where I need your help on this. Just a little bit of backup on that.
Great. And Dr. Jackson, it sounds like you have an extensive program and successful. And Greg brings up a really good point. I think if we had one infection that we'd want to focus a ton of our energy on, because there's a lot of inappropriate antibiotic use, would be around UTIs. Do you have any specifics, or can you tell us a little bit about your program and how it's worked in decreasing maybe the number of UTIs diagnosed?
Yeah, I still struggle with like the UTI thing. I think most people do. We trigger a lot for those, just because I think still breaking that culture of checking the UA for the confused patient is challenging. We've come a long way. And I think the biggest thing that's been successful with the program too is reducing our fluoroquinolone use. We used to have a ton of, that was kind of like the community culture up here for a long time, was just using a lot of Levaquin. And we have markedly decreased that. So now we really just reserve that for, Pseudomonas when it's appropriate and those kind of things too. So that's where it's been successful. But yeah, I feel like it's ongoing education all the time, like, because we usually meet in the fall to go over the program, make sure we don't need updates, and then rolling it out to the providers, rolling it out to the nursing leadership, and then making sure that they're, continuing to educate their floor staff too that are working with us. So it's an ongoing process. And then just like teaching in the moment of like, well, yes, that's, I know you want to check the UA, we really struggle with families too. I don't know about you guys, but I think families are hard too, and providing that education for them is key, because that's kind of they've always been taught, well, if they're confused, you should get their urine checked, when it just could be their dementia waxing and waning. So I really think the education is the big thing and ongoing all the time.
I think one of the things that we've tried, and I think it's been successful, Josie, is we actually try to avoid allowing people to order a UA. So one policy, and we'll send this out with the sample policies, but one policy that we've done is you can order labs, you can order, whatever labs you want, and then we check frequent vital signs overnight. And so we wait until those labs, and arguably, even if a patient has dysuria, and especially if they're confused, and we push fluids and we check their vital signs and they're stable overnight, and then the next morning, the labs are normal and the patient feels better, then we don't even get the urine in the chart. Do you think that's successful, Josie?
Yes, it is. But also, like I said, sometimes I do run into some pushback from some family or a resident themselves who's advocating for themselves, and that's perfectly okay. For that, I usually keep the urine dipsticks on hand, and I say, okay, so instead of that, how about we check it this way until we get the labs back in? We can kind of compare both and contrast both and see where we go from there. If we actually really need to send out this urine for an actual workup at the lab, that usually does placate a little bit, and it gives us a good indication of what's going on as well.
Okay. Travis has his hand raised, and I was going to call on him anyway.
Can you hear me?
Yeah.
Okay. So yeah, I think the UA piece, and it's a low hanging fruit, but since we know that the emergency room visits, especially for existing patients, so not a new patient that's come in, not a new admission, but an existing resident that goes to the ER and comes back, it's almost a foregone conclusion that we can expect, if confusion is part of the presentation, an antibiotic. So that is a kind of a low hanging fruit item that I think can be specifically addressed, whether that's through a protocol with the facility or these direct communications with providers to, again, empower them to stop the antibiotics. And something Josie said that resonated with me is kind of sharing the successes. So sharing, hey, we stopped these 3 antibiotics last month. If I was a provider and I heard that really kind of settles in, and I think empowers me to do the same. So, I think, and you don't have to be specific, it could just be, we had, these generic situations and here's what we did, and this is part of our stewardship program. So, I think that's kind of again, a low-hanging fruit area that would cut off a lot of inappropriate antibiotic use.
Well, and I appreciate that. And I think that's something that we could start doing, Josie. I'm not sure that we do share it with the providers, the successes. Another question for you, Travis, as a provider, and if you go to a provider meeting and someone's suggesting that, you know, you only need to or treat a UTI for 3 days or cellulitis for 5 days, how does that resonate with you? Are you, I mean, do you have us try to use specific lengths of times for antibiotics, or do you say, well, I'm the provider, I can do whatever I want and I can order from how long as I want?
Yeah, I mean, I do shorter courses because I do all the reviews, so I'm pretty aware of the differences. But you know, I do relate to this shift, this change, and of using shorter and shorter courses. And so, you know, fundamentally, it's just a matter of reminding providers that this is the current standard. This is what we do, and I think constant reminders that, you know, they're in a nursing facility. We have 24-hour care. We have monitoring. We can watch people. We can push fluids. You know, we can have these shorter courses. And if things turn, you know, some reassurance that in fact we are keeping an eye on them because, you know, we know they did have an infection. So, you know, I think that kind of reassurance goes a long way with providers that might be a little resistant to doing some of the shorter courses.
That's excellent. That reminds me, Dr. Jackson, have you guys used antibiotic timeouts? Is that something that, so I think I think Travis brings a really good point. So we try 3 days, we try a short course for cellulitis, and if it's getting better, great. We know we've done the right thing. If not, we could extend it. Is that something you guys have looked at?
In our protocol, we did like the, you know, like for UTIs, it's 3 days, and we tried to, when you're ordering it off our sheet, we did the smaller time frame. And then we always talk about how if you need to extend beyond that, it's important to reevaluate somebody to make sure it's working, but then, you know, if you do need to extend it, then you can do it that way, but not to just reflexively order the 14 days. So just because we're a small group and it's hard to sometimes do the timeout and have people there to follow up immediately. Like that's what we've done, is try to make sure that we're always prescribing the shorter amount first and then going from there.
That's excellent.
Mm-hmm. I was also going to say, I love the IOU study, the toolkit. I love that thing. And so that's what they've got some great case studies and ways to talk to staff. So I'll put the link in here, but it's on the AMDA website. And we used a lot of that to kind of help us with our durations of antibiotic therapy.
Okay,
So,
seeing maybe we can send that out at the end and include that in the email.
I'd be happy to.
We're running up against the time. Is there any questions or any comments from the rest of the audience? So in the future, you know, if you want specifics, we could have probably a whole smaller, shorter session. We could talk about UTIs. We could talk about specifics. We could, you know, probably get a lot of information from Travis and doing all of this reviews and what he's actually seeing from providers. But please let us know what you want to see in the future. Are there any other questions or comments?
Well, I'm happy to include any resources that people on the panel want to share with all of CMDA. We can email it out to the group. And you can see in the chat box, there are already some links to really great resources from Rebecca Jackson and Lauren Bealey.
And I would just add that, you know, since I am, you know, I'm basically on like the email chains and lists for getting all the latest on antibiotic resistance. And, you know, it is getting worse. And so we don't see these patients because they go to specialty hospitals for, you know, superbug infections, but it's happening in greater numbers. So that trend combined with the growing sort of science around gut microbiome and what antibiotics might be doing, you know, is certainly more and more evidence that we need to be a lot more discerning about the antibiotic use. So just kind of a reminder for everybody, and that in fact, you know, when these protocols are put in place too, you don't see more hospitalizations, you don't see, you know, a greater mortality, you see better clinical outcomes. And you can remind providers too that when you have something like the low criteria, McGregor criteria, it's a guideline. It's not set in stone. We're not trying to enforce something to the letter. We're trying to stick to protocols we know that work, but it's still individualized care. We'll still monitor people. And so again, kind of reminding everybody that, this is not like the police force. This is about, appropriate use that actually results in better clinical outcomes.
Perfect.
Well put. Thank you. What a great ending to this conversation among some very experienced providers. Well, thank you all for joining. If you have questions for the panel, feel free to ask them really quick in the chat box or stick around. But this is the end of our meeting today. We appreciate all of you joining us. Thank you.